Medicina veterinaria es sobre diagnóstico, completo y precoz. Con IDEXX, su clínica puede realizar un chequeo 360 en pocos minutos. Con IDEXX tienes prueba rápida y SNAP, hemograma en ProSite One, un perfil bioquímico amplio, incluyendo el SDMA en el Catalyst One. Y ahora concluimos el análisis de orina con el UA y con nuestro nuevo SediVue DX. ¿Y sabes qué es aún mejor? Todos esos resultados estarán listos en menos de 15 minutos. ¿Ves qué rápido es obtener el diagnóstico 360 de tu paciente aún durante la consulta? Ahora con los resultados en mano, listo para que cierres el diagnóstico de tu paciente, sin complicaciones, eficiente y en el momento que lo necesitas.
Everyone, thanks so much for joining us today for a discussion on pancreatitis and lipase testing. My name is Beth Schooley. I am a medical affairs specialist at IDEXX, and one of my special interests is our GI franchise, and so talking about pancreatitis is well up my alley. I went to veterinary school at Colorado State University and then followed that up by an internship in small animal medicine and surgery at the Animal Medical Center in New York City. Following that, I did my residency as well as a master's degree at the University of Missouri in Columbia, Missouri. And then moved to Virginia, where I was in private practice before joining IDEXX. I've been boarded by the American College of Veterinary Internal Medicine as a small animal internist since 2007. So really excited to talk to you today about pancreatitis. So I'm going to start this discussion looking at 3 different cases. So the first one is Archie. He's a 6-year-old miniature schnauzer. He was recently at a family reunion, and a couple of days after the reunion, he started having some clinical signs. He didn't eat his food, he wouldn't play, he was vomiting several times, and so the pet owners brought him into the veterinarian. On physical exam, he had a bit of a fever. His pulse and respiration were reasonable, but he was quite a bit dehydrated. And when the veterinarian went to do an abdominal palpation, he actually, turned around and nipped at them, which is, something that I think all of us are familiar with in cases of abdominal pain. Then the second case is Oliver. He's a 7-year-old male-neutered domestic short hair. For his history, he's got a progressive history of decreased appetite and weight loss. He's been lethargic for about a week. And over the last 6 months, he's had some intermittent episodes of vomiting and diarrhea. Physical exam for him in general was pretty unremarkable, but when his abdominal palpation was done, there was sort of this non-painful mass effect in his cranial abdomen that the veterinarian felt. And then our final case is Maisie, and she's a 15-year-old female spayed Chattanooga boxer mix. And being an older girl, she certainly has some old girl problems. She's got a history of mitral valve disease, some osteoarthritis, and recently she had a dental with several extractions. And she's now presenting back to the veterinarian due to lethargy and some diarrhea. On her physical examination, she had a normal TPR, body condition score of 5 out of 9. Her oral cavity was healing really well from her dental from the previous week, and her heart murmur was stable. So, but still kind of had that not quite right look to her. So when I think about all of these patients, all of them have a very different presenting history and physical exam findings, but all of them should lead us to consider pancreatitis. Archie is a very classic acute pancreatitis case, whereas Oliver and Maisie seem to have more of that slower chronic pancreatitis, where they're kind of having some intermittent signs, not quite feeling real well, and potentially those guys are a little bit more on the chronic side. The reason I bring this up is just to really show you the variety of cases that we can see when patients present for pancreatitis. All right, let's talk a little bit about pancreatitis in dogs and cats. One of the key points that I want to bring across to everybody is that both dogs and cats get pancreatitis, and it's a relatively common problem in both of our species. Additionally, both species get both acute pancreatitis as well as chronic pancreatitis. So let's start by talking about the definition of acute and chronic pancreatitis. So acute pancreatitis is reversible inflammation in the pancreas. These animals can present clinically mild or quite severe. They tend to present acutely with clinical signs that the owner kind of notes coming out of nowhere. In severe cases, animals can get an acute necrotizing pancreatitis, which is a life-threatening condition. But remember, you can also get a mild acute pancreatitis where you're just having, smaller episodes of vomiting and abdominal pain. One thing about acute pancreatitis is that it can lead to chronic pancreatitis. So what's the difference with chronic pancreatitis? Chronic pancreatitis is a continuing inflammatory process that occurs in the pancreas that's accompanied by irreversible changes such as fibrosis. Flare-ups of chronic pancreatitis can occur, so you can have these waxing and waning episodes in animals with chronic pancreatitis where they get these acute episodes in between their kind of chronic ongoing clinical signs. Often our chronic pancreatitis cases are quite manageable with monitoring and diet. Now, I said before that we see pancreatitis in both dogs and cats. It's really hard to say exactly what the incidence of pancreatitis is, because the clinical signs of pancreatitis can be so subtle and nonspecific. And so there's really not a true gold standard in terms of making the diagnosis. And therefore, the prevalent studies are rather sparse. But when I looked at one study of clinical signs that dogs and cats presented to their primary care veterinarians for, I looked at those common clinical signs, and what I noted was that 11.3% of the clinical signs that dogs showed, and about 23% of the clinical signs that cats presented to their veterinarian for could lead to a clinical suspicion of pancreatitis. And so that's a lot more than I think most people would recognize. Now, what I'm not saying is not all of these animals have pancreatitis, but we as veterinarians should consider pancreatitis in these dogs and cats. So the clinical signs were things like vomiting, lethargy, anorexia, weight loss in cats, things like that. all of those are clinical signs that we'll see in these patients. The other studies that look at the incidence of pancreatitis were done in the early 2000s. And in these studies, they looked at animals that presented for necropsy at a university for one reason or another. And what they looked at was histopathologic lesions in the pancreas of these patients. And in these two studies, there was one in dogs and one in cats, they noted that about 65% of dogs and cats end up having some sort of pancreatic lesion when they present for necropsy. Now, the downside of those studies is just because you have a lesion in your pancreas doesn't necessarily mean you have clinical pancreatitis. So those incidents are probably a little bit overblown compared to the true incidence of pancreatitis. But again, when these studies came out, it did sort of start bringing pancreatitis back into our vision as something that is more common than we once thought. So I want to talk a little bit over the next few slides of, a little bit about dogs and a little bit about cats. So in terms of who is at risk, in dogs, we know that there are several breeds that are predisposed to both acute and chronic pancreatitis. In acute pancreatitis, we often think of our miniature schnauzers, our Yorkies, and some of our other terrier breeds. While as chronic pancreatitis, we tend to see in several of our spaniels, boxers, and collies. Cats, on the other hand, we don't have any studies that show that there's a predisposition to pancreatitis based on age, sex, or breed. In dogs, we often think about factors that can lead to pancreatitis, such as eating a fatty meal or a hypertriglyceridemia that's chronic, leading to pancreatitis. And in dogs, these are definitely risk factors for the development of pancreatitis, but we have to recognize that in cats, they're not small dogs, and there's actually no association with hypertriglyceridemia or fatty meals in the development of feline pancreatitis. In dogs, again, we've got several studies out there, case reports, that indicate that there are some medications that can predispose dogs to getting pancreatitis. In cats, we don't have those similar studies. I can't say that no drugs could lead to pancreatitis in cats, but from my understanding, I don't know of any known association with specific drugs. Now in cats, we do know that autoimmune disease may play a part in feline pancreatitis. And one of the reasons we know this is that a lot of cats actually respond to anti-inflammatory medications when they've got pancreatitis, which leads us to kind of backtrack into this consideration that there might be an immune-mediated component. And then finally, in both dogs and cats, to different degrees, you have miscellaneous causes of pancreatitis. So systemic infectious agents, pancreatic trauma, hypotension, neoplasia, and snake bites from certain breeds of snakes. So certainly those are some of the risk factors we've seen associated with pancreatitis. But one of the big things that I always kind of go back to is often we don't know what actually caused the pancreatitis. Our most common etiology is idiopathic, where we never ultimately get to the bottom of it. So let's talk about clinical signs. In dogs, the most common clinical signs that you're going to see are vomiting, lethargy, anorexia. Sometimes owners will bring them in for behavioral changes, especially with our chronic pancreatitis cases, where once they were kind of happy and bouncy and now they're kind of slowing down, they're not feeling quite as well. Some of those clinical signs, some of those, he's getting older, maybe he's just slowing down, that can sometimes be associated with pancreatitis. Some dogs will get diarrhea, and some dogs will certainly be presented for weakness. And I kind of put that together with that behavioral change that owners might see. In cats, again, very non-specific clinical signs. Often we see them have lethargy, anorexia, potentially some vomiting and weight loss, potentially some diarrhea, and occasionally they'll have some dyspnea from either secondary effects on the lungs or just due to discomfort. One thing I think is really important to think about, because we don't think about pancreatitis in cats as much as we should, is that we really should kind of have that on our brains for any cat that kind of presents for a non-specific illness, a non-specific clinical sign. We might want to just make sure that we're keeping pancreatitis in mind. So for physical exam, what we tend to see are in dogs and cats, quite frankly, is dehydration. Both species will potentially show abdominal pain. It's more common in dogs than in cats. Some of that might be because we're better at recognizing abdominal pain in dogs than we are in cats, as well as cats tend to hide their disease a little bit longer than dogs, as we all know, with our feline patients. Other things that you'll see on physical exam are evidence of systemic complications that can occur with pancreatitis. So you may see an increased respiratory rate and effort, potentially some neurologic signs, bleeding due to disseminated intravascular coagulation, potentially icterus due to secondary effects on the liver. And that's similar for both species. And occasionally in dogs, you can see abdominal effusion, and in cats, an abdominal mass or some cranial abdominal megaly that you're feeling on your abdominal palpation. So we often see comorbidities and complications associated with pancreatitis. And the comorbidities can be different between dogs and cats. In dogs, we often see hypertriglyceridemia. We can see diabetes mellitus and diabetic ketoacidosis associated with pancreatitis in both dogs and cats. And we have to remember that the pancreas is responsible for both insulin production as well as production of digestive enzymes. And so when you have pancreatitis and inflammation in the pancreas, you may cause some damage to the pancreatic beta cells, which ultimately could lead to a diabetic state. In dogs, as well as in cats, you can sometimes get exocrine pancreatic insufficiency as a follow-up to chronic pancreatitis. Again, in chronic pancreatitis, you've got these irreversible pancreatic changes, these irreversible inflammatory changes, which can ultimately lead to decreased numbers of pancreatic acinar cells and decreased digestive enzyme production. In dogs, a lot of time, we do see pancreatitis associated with Cushing's disease, as well as hypothyroidism. And in cats, we tend to see something called triaditis in cats, which is a combination of pancreatitis, chronic enteropathy, as well as a chronic hepatopathy. And so we're having to deal with those all together in our management of the disease. In animals that have a severe pancreatitis, you certainly can see some significant complications of the disease. So you can see everything from acute kidney injury, pneumonia, a vasculitis type of an episode. You can see acute lung injury, DIC, and a systemic inflammatory response syndrome. So these are very significant, severe complications that can decrease the prognosis for animals with acute pancreatitis. As I discussed above, we also can see exocrine pancreatic insufficiency secondary or as a complication of some pancreatitis cases. So I want to talk a little bit about the pathophysiology of pancreatitis. So let's go back to our vet school days and think about where the pancreas sits in the body. So the pancreas is kind of a curved organ that sits sort of folded into the bend of the duodenum and kind of curled between the liver, the stomach, and the small intestine. And so it's in very close approximation to those organs. And that kind of helps us understand why we see some of the complications that we do. In most cats, the pancreatic and common bile ducts merge just before the duodenal papilla. That happens in about 75 to 80% of cats anatomically, whereas in dogs, most dogs have a distinct pancreatic duct and a distinct common bile duct. Both species can have exceptions because we never like to follow all the rules. But in general, that's sort of the anatomy of these two species. And is one of the reasons that felines can get predisposed to chronic pancreatitis is because this common duct. So from a physiology standpoint, we've already talked about this a little bit. You have your exocrine pancreas, in which the acinar cells produce digestive enzymes that are inactive forms, also called zymogens. And then we have our endocrine pancreas, which contains the beta cells that produce insulin. Let's talk a little bit. The pancreas is a really interesting organ because there are a lot of protective mechanisms that help minimize the chances that we're going to develop pancreatitis. So the first thing which I want to discuss is that those digestive enzymes are actually inactive when they're within the pancreas. So the first thing the pancreas does to minimize chance of problems is to make the enzymes inactive so that they can't cause inflammation within the pancreas. We also have within the pancreatic acinar cells these little membranes that kind of go within the cytoplasm that kind of separate the enzymes into different zones within the cell. So again, a way to minimize that the enzymes will interact and lead to inflammation. There's also a protein called SPINK1. And what that protein does is if these first two mechanisms fail, and we do get some active pancreatic enzymes within the pancreas, the SPINK1 protein actually goes and deactivates those enzymes within the pancreas, again, to minimize any inflammation. The acinar cells have a lower pH, less than 5, which decreases the chance that those digestive enzymes will become activated. And then anatomically, there's unidirectional flow within the pancreatic duct, which minimizes the chance that you're going to have kind of a retrograde movement of digestive fluid and bile into the pancreas, which could cause an insult to the pancreas itself, leading to pancreatitis. So the pancreas has really, over time, become an organ that has created an environment that helps minimize the chances of pancreatitis. Unfortunately, we can still see pancreatitis. And on a very basic level, for pancreatitis, what we tend to see is that there's some sort of an insult to the pancreas. Then we get cytokine production, which leads to inflammation in the pancreas, which ultimately leads to that pancreatitis. So that's kind of the very basic pathophysiology behind pancreatitis. Now, if we want to look more in depth, we'll look a little bit more in this slide. So first we have that pancreatic insult, and that can be sort of anything that we've talked about before. So it could be trauma to the pancreas. It could be that there's retrograde movement of bile or gastrointestinal digestive material into the pancreas. It could be that the pancreas isn't getting enough blood supply, for instance, hypotension under anesthesia. So any of these insults could ultimately lead to premature activation of the digestive enzymes. Ultimately, that leads to local cytokine formation, which then leads to disruption of the pancreatic cellular membranes, increased vascular permeability as this inflammation kind of continues to permeate. You'll get edema and potentially hemorrhage within the pancreas. Those leukocytes will start infiltrating more, and you can get peripancreatic fat necrosis. One thing to recognize is that the inflammation itself is independent of trypsin activation, but it is dependent on the ongoing stimulation of inflammatory pathways. So it's kind of that inflammation leads to more inflammation, which ultimately causes a problem. Let's talk a little bit about diagnostic testing options in pancreatitis. So one thing I really like to talk about at the beginning is that the diagnosis of pancreatitis is really based on a combination of clinical suspicion, diagnostic testing results, as well as ruling out other causes of the clinical signs. So first, we have to have our clinical suspicion with an appropriate history, physical exam, and suggestive laboratory results on our CBC, chemistry, and urinalysis. Then we'll oftentimes follow it up by additional laboratory testing, such as specific pancreatic lipase. Imaging is quite important to help rule out other secondary diseases. And in some cases, we may do cytology or histopathology to confirm a diagnosis of pancreatitis. That's not done as often in clinical practice, especially in a general practice, but it is a tool that can be used. So let's talk at first about the minimum database. So in general pancreatitis, you don't have very specific findings on your CBC, chemistry, and urinalysis. But these tests are very important to do because they help give us supportive evidence that pancreatitis may exist. It can help us understand the severity of disease and the prognosis that this patient may have. And it helps us understand any concurrent illnesses that we have to manage. So on hematology, you can see anemia. Oftentimes you'll see elevated white blood cell count, potentially with bands. Sometimes you'll see a thrombocytopenia, especially in more severely affected animals. And you can get a decrease in your reticulocyte hemoglobin on your CBC, which is an indicator of inflammation. On a biochemistry profile, a lot of the findings that we're looking at on your chemistry are looking for secondary organ issues. So we may have elevations in our liver enzymes. An animal could have azotemia due to either dehydration from the pancreatitis, or sometimes pancreatitis can ultimately lead to acute kidney injury due to some of the inflammatory pathways. CRP is a great test looking for systemic inflammation, and that will be elevated in dogs with pancreatitis. Albumin can sometimes be decreased. Glucose depends. It can be a little bit up or it can be a little bit down. Same with calcium. Triglycerides can be elevated as well as cholesterol, but not always. I also really always recommend a urinalysis that can help us understand if there are some underlying issues, such as development of an acute kidney injury, by looking for casts. Also, a urine cystatin B, which is a relatively new test on the market, is a marker for acute kidney injury. So if we have an elevated urine cystatin B, that is an indication that the kidneys may be having a secondary effect from the pancreatitis. So that's our minimum database, but we also need to look at some other additional testing. I think it is really important to do some sort of abdominal imaging. The biggest thing that I'm looking for here is to rule out foreign bodies or other diseases. And so radiographs are terrific to help rule out your foreign bodies. Ultrasound also is a great tool to use in these cases. We can use it to help rule out other diseases. We can evaluate the pancreatic tissue itself, as well as evaluate for effusions and potentially collect effusions or a pancreatic aspirate. The sensitivity of ultrasound varies quite a bit, and it is dependent on your operator skill, the equipment that we use, as well as the severity of disease. One thing to remember is if you have a mild pancreatitis or a chronic mild pancreatitis, you may not see the same changes as you would with an acute fulminant pancreatitis. There are also studies out there that show that serial ultrasound exams can improve the diagnostic sensitivity of ultrasound for pancreatitis. There are studies out there looking at advanced imaging. It's certainly not something that's done very often, even in our referral institutions, but there are studies looking at contrast-enhanced ultrasound, CT, and MRI, not something that we do on a regular basis. Now, cytology and histopathology, I'm going to mention them here because I think sometimes they do get a little bit of a bad rap. So both cytology as well as histopathology, taking biopsies for histopathology, is quite safe as long as we're being gentle with the pancreatitis and we're not, and we're following good techniques and not overdoing it. But it's quite safe. You don't have to worry about making the pancreas more angry by taking an aspirate. Now, so neither of these are done in routine clinical practice, but if they are performed, they can have a very high specificity. So if you see inflammation along with your acinar cells on your pancreatic cytology, that's quite specific for pancreatitis. But if you don't see that, it doesn't rule out pancreatitis. So cytology is highly specific, but has a low sensitivity. Histopathology, as we talked about before, we certainly can do histopathology if an animal is undergoing a surgical procedure. It's reasonable to take biopsies, but just because they have a pancreatic lesion doesn't necessarily mean that it's clinically relevant. So it's not something I would do on a routine basis. From there, I really want to talk about our lipase assays. There are a lot of different lipase assays that are available, and they're not all the same. So I like to break these into two different categories. We've got our activity assays, and these are some of our the lipases that we use at the IDEXX reference laboratory as part of our larger panels, as well as a new test that I'm going to be introducing, which is called catalyst pancreatic lipase. So in these activity assays, what we're looking for is that there's a chemical in the test itself that when you add pancreatic lipase, or when you add lipase from your blood sample to the chemicals that are part of the assay, it's looking to see how much of that chemical is being broken down, because the chemical sort of mimics fat. And so we're looking to see if there's a lot of lipase in the bloodstream, it's going to break down more of that chemical than if there's very little lipase in the bloodstream. And in a normal animal, you wouldn't expect to have large amounts of lipase. So the specificity for pancreatic lipase varies among these different assays. So we have to remember that there are different forms of lipase, and what we really want to look for in cases of pancreatitis is pancreatic lipase. These activity assays are traditionally measured in a unit per liter measurement. Immunoassays on the other side of it, and examples of an immunoassay include the IDEXX SPEC-CPL and SPEC-FPL, as well as our SNAP-CPL and SNAP-FPL. And these types of lipase tests use species-specific antibodies against canine or feline pancreatic lipase to measure the amount of binding of those antibodies to the pancreatic lipase. These assays are very specific for pancreatic lipase, and they're typically measured in micrograms per liter. So I'm going to switch a little bit and talk a little bit about our new test, our Catalyst Pancreatic Lipase test. So this is a test I'm really excited about because what it offers is a real-time pancreatic lipase test that we can use in clinic to help diagnose pancreatitis in dogs and cats. It's accurate, and it's quite specific, and it aligns to our IDEXX reference laboratories SPEC-CPL and SPEC-FPL tests, which tend to be considered the gold standard test for measuring pancreatic lipase. The great news about this is it is an activity assay, so it's not species specific. So we can use one slide on our Catalyst for both dogs and cats, which really makes our workflow within the clinic much easier than having to have a different test for dogs and cats. We can also run it alone or along with our chemistry panels. And as with our other Catalyst tests, it's kind of that easy load and go format, and our results will be integrated into VetConnect Plus. The other really nice thing that we did with Catalyst Pancreatic Lipase is we were able to calibrate our Catalyst Pancreatic Lipase test directly to SPEC-CPL and SPEC-FPL, which allows us to have the similar interpretive guidelines and then similar cutoffs. So what you'll notice is for dogs, depending on whether you're using a SPEC test or a Catalyst test, the units will differ, but the numbers themselves should be similar in terms of your interpretive buckets on, dogs. A normal dog should have a pancreatic lipase, whether it's on Catalyst or on SPEC, of less than 200. For cats, that's less than or equal to 4.4. And along in those different buckets of our gray zones, as well as our concentrations that are more specific for pancreatitis. So let's talk a little bit about how we validated the Catalyst PL test. So our first test, whenever we're looking to validate a test, is to compare our new test to our reference method test. And in this case, we used our SPEC-CPL and our SPEC-FPL tests as our reference method. And what you can see from these graphs is that we have very good alignment between our Catalyst test and our SPEC test. The dotted line is sort of is absolute agreement. So if every single dot was along that line, that means we agree 100% of the time. Understandably, in real life and real medicine, we don't agree 100% of the time. But what we're looking for is that the line between the dots, the line of best fit, which is the red line, is as close as possible to that dotted line. And we measure that with a statistic called the R value. And what we're looking for is how well those tests align. And an R value greater than 0.9 means excellent alignment or excellent correlation. And what we can see for both dogs as well as cats is we have terrific alignment between our catalyst assay and our SPEC assay. Another way to look at this is to look at something called a contingency table. And in these tables, what we're looking at is whether our results, the same samples that we used in the method comparison on the previous slide, we want to see if those results lead to a similar clinical interpretation. So do they end up in sort of that same interpretive bucket when we're interpreting them clinically? And so we've got our SPEC CPL results, or our SPEC results along the top for dogs and cats, and then our catalyst results on the slide. The outlined cells are the number of, or the percent of the overall tests that are in agreement. So all of the cells will add up to 100%. And 84% of the time in dogs, 87% of the time in cats, we have perfect agreement in terms of that clinical interpretation or that clinical interpretive comments. And those are the highlighted boxes that go across the diagonal. When our results don't agree, what we'll tend to see is that they may be a little bit on one side or the other of the gray zone. But in both cats and dogs in this set, we don't see any results where an animal on one test is normal and on the other test is in a consistent with pancreatitis category. So again, this shows great agreement and alignment across our two different assays. The other thing we like to look at in assay validation is how precise an assay is. And precision is basically, if I run the same sample over and over and over again, will I get the same result? And in these charts, what you'll see is that we did this kind of testing in both our dogs and our cats on both the Catalyst DX and Catalyst 1 analyzers. And what we note here is that the percent CV, or the percent coefficient of variation for both dogs and cats across different concentrations of catalyst pancreatic lipase have low CV values. So they're all in the single digits. And a CV value less than 10% for this type of assay is really quite good. So when we run this test over and over and over again, we're getting very similar results across our testing. The last study I want to show you is a study looking at German Shepherd dogs with exocrine pancreatic insufficiency. And it's going to help us understand the analytical specificity of catalyst pancreatic lipase for pancreatic lipase. If we remember back to our early education, lipase is an enzyme that is produced not only by the pancreas, but also by other organs in the body. So it can be produced by the kidneys, by the GI tract, by the vascular endothelium. There are all kinds of lipases around our body. To diagnose pancreatitis, though, we want a test that's specifically looking at pancreatic lipase and isn't picking up on these other types of lipase in the bloodstream. So in this study, what we did is we looked at German Shepherds that had exocrine pancreatic insufficiency. And the reason that we're looking at German Shepherds is they get a condition called pancreatic acinar cell atrophy, where they basically are not making any pancreatic lipase. And so when we look at a lipase test on these dogs, if we're measuring a significant amount of lipase, it's not coming from pancreatic origin, because we know that these dogs are not making pancreatic lipase because their pancreas is basically kaput. So in this slide, what you'll see is 3 charts. And on the first one, you've got our catalyst pancreatic lipase on the y-axis. And then on the x-axis. On the y-axis, you have our concentrations. And each dot represents one dog, one German Shepherd with exocrine pancreatic insufficiency. And what you can see here is that all of the dots line up on this dotted line at the bottom, which is the lower limits of quantification of the test. So that's as low as the test will go, and we're not seeing any pancreatic lipase on our catalyst PL assay. The red line here is 25% of our normal reference interval. So a normal reference interval in a dog goes up to 200. And so the red line is the lower 25% of that. In all of our samples, we're below that line. Now let's look at the SPEC CPL test. The graph is set up similarly, where we have a very low concentration of pancreatic lipase that's along that lower limit of quantification, which is what we would expect in these dogs. And none of our samples go above 25% of our normal range. In our third graph, this is a graph of an older assay, pancreatic assay, that we've used historically, called the 1,2 diglyceride assay. And in this case, what you'll see is that our samples of dogs with EPI, we do have samples that go above our lower limits of quantification. We're actually seeing lipase in these cases, but we know that these dogs don't have pancreatic lipase. So the lipase that we're seeing in this graphic is lipase from another source. So this 1,2 diglyceride assay is not as specific for pancreatic lipase as our catalyst pancreatic lipase or our SPEC CPL lipase. So this is a study, again, that shows that specificity of this test for pancreatic lipase, which is what we really care about in the diagnosis of pancreatitis. So I talked about several different assays that are available. And so which assay should we use in our different situations? So at the point of care, we have a couple of options. We have our targeted lipase tests. So these are the lipase tests that are really targeted for pancreatic lipase. We have our new catalyst pancreatic lipase test, as well as our SNAP CPL and SNAP FPL test available in clinic. The catalyst pancreatic lipase test is closely aligns with our SPEC test. It's quantitative, so we will get a value that we can monitor over time. And it's best used in cases where they're in the hospital, you want your results within 10 minutes of running the test. So this is a test to use in hospital when you need results immediately. At our reference lab, we have the targeted test, the SPEC CPL and SPEC FPL, and that's available for cases where you want to send your pancreatic lipase testing into the lab. Again, with that test, you can rule out pancreatitis, diagnose or monitor pancreatitis because they're quantitative assays. One thing that I do want to mention in terms of the term rule out, pancreatitis, especially chronic pancreatitis, you can have lower lipase values at times during that disease process. And so when we say rule out, we're saying ruling out pancreatitis as the cause of the current clinical signs. Not necessarily that pancreatitis won't happen in a day, or that we won't see an elevation in pancreatic lipase in a day, in a week, in a month. You still may see that over time in these chronic pancreatitis cases where lipase values wax and wane. For our SNAP CPL and FPL tests, those are semi-quantitative tests. And so they can help us rule out pancreatitis as the cause of the current disease. But because they're not quantitative, we do recommend following those up with a SPEC CPL or a SPEC FPL test in the lab to help us diagnose pancreatitis as the cause of the clinical signs. We also have available some general lipase tests. So we have Catalyst lipase, which is available on our Catalyst Chem 17 clip, as well as lipase in our larger biochemical profiles within the laboratory. These assays aren't as specific for pancreatic lipase. They can potentially pick up on other forms of lipase. So they're good as screening tests to assess overall health. And they're run as part of those comprehensive profiles. If you have significant elevations of either of these tests, then we would recommend following them up with one of our targeted pancreatic lipase tests if you have a clinical suspicion of pancreatitis. So let's talk a little bit. I always like to finish these presentations talking about a real life case. So I'm going to go back and talk about Oliver, who was one of the examples I used at the beginning of this presentation. So just to remind you, Oliver is a 7-year-old male castrated domestic short hair. And his history was he kind of had this progressive decreased appetite, some weight loss, lethargy, and some occasional vomiting and diarrhea over the last several months. So when his owners brought him in for physical examination, basically he had normal vitals, he had maybe some mild dehydration, he was a little bit quiet, but nothing out of the ordinary. But he did have sort of this potential cranial abdominal mass that did not seem painful. Because of that cranial abdominal mass and his clinical signs that he was showing at home, let's kind of talk about his problem list. So when I think about it, we're talking about a decreased appetite, weight loss, and lethargy, pretty non-specific signs, as well as dehydration. Again, pretty non-specific, almost anything and everything can lead to that. So when I think about my differential list, it's going to be pretty broad. We've got our metabolic diseases, infectious diseases, neoplastic diseases, cardiac diseases, immune-mediated diseases. So we kind of have all of those things that ultimately could lead to some of these clinical signs. The other thing that he had, which was a little bit more specific, was the vomiting and diarrhea, which could be due to primary gastrointestinal disease, such as a chronic enteropathy or GI parasites or things like that. Or it could be a non-GI cause of vomiting and diarrhea, such as pancreatitis, kidney disease, liver disease, any of our metabolic type diseases. So from here, based on this differential list, the veterinarian went ahead and did a CBC and chemistry panel on their in-house equipment. And what they noted on their CBC was an elevated white blood cell count. And that's mostly due to a neutrophilia with some suspected bands. And remember on your in-house analyzers, when you have the little stars next to the results, what that means is that the analyzer might be having a little bit of trouble telling the differences between different types of cells because the cells may be a little bit different in size or in shape. And so those stars indicate to me that you should look at either your dot plot or at a blood film evaluation. And you'll want to do that to confirm that you've got the bands that we're noticing here. These suspected bands you want to confirm by looking at your dot plot or a blood film evaluation. On our chemistry profile, we've got some fairly non-specific signs. We've got a very mild hyperglycemia, a mild elevation in BUN, a little bit of an elevation in sodium, and a mild elevation in ALT. So all in all, our CBC and chemistry profile were pretty non-specific. But they also did have a suspicion of feline pancreatitis. And so they went ahead and ran a catalyst pancreatic lipase test. And that result was 8.5 units per liter, which is elevated and is an indication that we may have pancreatitis as part of the clinical signs. So again, looking at our problem list, we're now kind of looking more at the changes that we see on our blood work. And we see an elevated catalyst pancreatic lipase, which could be due to pancreatitis, or potentially a secondary pancreatic inflammation from some other underlying disease process. The increase in glucose, to me, it was very, very mild. And so likely that was a physiologic response, or sometimes you can see an elevated glucose with animals with pancreatitis. Our sodium was increased, which may be due to gastrointestinal disease from our vomiting and diarrhea, or decreased water intake. And then again, we had an elevation in ALT, which was likely due to some sort of underlying liver pathology, which could be primary to the liver or a secondary effect on the liver from another disease process. And of course, ALT can go up with muscular disease, but in this case, with his clinical signs, I would certainly be leaning more towards liver in this case. So the veterinarian went on and did an abdominal ultrasound. And what you can see on this ultrasound, on the left-hand side, we have the pancreas, and it is sort of this black area in the middle of our ultrasound. What you can see from that is that it's pretty irregular in shape. You can kind of see how it's not nice and uniform. It's also pretty wide and thickened, which those can be indicators of pancreatitis in cats. We also have on the right some graphics of his small intestine. And those intestines do look a little bit thickened comparatively to a normal feline intestine. So ultimately, Oliver was diagnosed with pancreatitis, chronic pancreatitis, based on these findings. And he was treated with subcutaneous fluids. He was put on a little bit of prednisone to help with the inflammation, as well as an appetite stimulant, and his diet was changed to a very palatable, highly digestible diet to get him to eat a little bit better and a little bit more. Ultimately, over the next several days, he improved quite substantially, and in the long run, his vomiting and diarrhea decreased, and he gained weight over the next couple of months. So all in all, great outcome for Oliver with his chronic pancreatitis. All right, just a quick summary of what we learned with Oliver. So first, we've got the diagnosis of pancreatitis in cats really needs to be based upon a combination of our clinical picture, our laboratory results, and then, a level of suspicion and intuition. It's the art of medicine. We also want to make sure we've ruled out other causes of his clinical signs. In cats, there's no real specific treatment for pancreatitis, so we want to tailor our treatment to the patient's clinical problems. And so in Oliver's case, it was managing his dehydration, getting him to eat better, as well as helping with some of that underlying inflammation in his pancreas and GI tract. Nutrition is ultimately an important part of therapy, but in cats, we're looking more at doing a highly digestible, a highly edible diet that they want to eat. And we don't necessarily have to worry as much about the low-fat diets that we classically think about for dogs. Generally, prognosis for chronic pancreatitis is quite good for cats, but they can have some waxing and waning episodes in some cases. So overall, great outcome for Oliver. Now I want to wrap up this presentation with just a few key takeaways, things that I'm hoping you took away from this. So remember, in both dogs and cats, they can have acute as well as chronic pancreatitis. We want to have a really well-rounded diagnostic plan to assure that our diagnosis is accurate and help us understand prognosis of these patients based on other disease processes, comorbidities that may be occurring. An elevated pancreatic lipase test indicates that there is pancreatic involvement, but we have to remember that pancreatitis may not be the only cause of clinical signs. So in some cases, you can have primary GI disease that causes some secondary pancreatic inflammation, or some kidney disease that causes some secondary pancreatic inflammation. So we always want to do that well-rounded workup to make sure that we're not missing another piece of our diagnosis. And then finally, we've introduced you to our Catalyst pancreatic lipase test, which offers a great option for testing pancreatic lipase in-house in real time so that you can manage your patients more efficiently. And this test correlates very well with our STEC-CPL and STEC-FPL tests. With that, I'm just going to throw up a slide with a few resources, and I want to thank you for spending some time with me today.